Well, good afternoon, everyone, and welcome to today's webinar from the Oklahoma City Indian Clinic titled Proven Ways We Increase CRC Screening Rates in Our Native Community. My name is Lois Brown, and I'm the nurse educator at the American Indian Cancer Foundation, and I have the pleasure of introducing our speaker today, Jessica Deaton. Jessica Deaton has 8 years of nursing experience. She graduated with her bachelor's in science of nursing in 2011 from the University of Oklahoma Health Sciences Center in Oklahoma City. The first 5 years were spent working at a cardiac hospital in Oklahoma City. She has been with the Oklahoma City Indian Clinic for the past 3.5 years, working as a registered nurse, care manager, colorectal cancer quality improvement leader. At the beginning of 2016, she was chosen to develop and coordinate a colorectal cancer screening program for the clinic and has continued to work towards increasing colorectal cancer screening rates within the American Indian population. OKCIC, Oklahoma City Indian Clinic, received the National Colorectal Cancer Roundtable National Achievement Award in 2018 for their colorectal cancer screening efforts. Oklahoma City Indian Clinic has also been recognized by the Oklahoma Primary Care Association, American Cancer Society, and the Indian Health Services Area Directors Awards. We have allotted 30 minutes for today's webinar, and we encourage you to ask questions, which will be answered at the end of the presentation. If you do have any questions, please type them in the chat box. Or if you are chatting or watching with us on Facebook, enter the question in the comment section. If we don't get to everyone's question, an email will be sent out with responses from Jessica after the webinar. So if you do have questions after the webinar, please email health@aicaf.org, and we will send a follow-up email answering your questions. Also, be on the lookout for a brief survey and an email containing the recording of today's presentation. The survey will only take a couple minutes, and we value your input. Now I'll turn things over to Jessica.
Hi, my name is Jessica Deaton, and I'm one of our care managers at the Oklahoma City Indian Clinic. I also chair our internal colorectal cancer screening quality improvement committee. Our current screening denominator is 3,545 patients. These account for individuals between the ages of 50 and 75 with any single clinic visit in the past 3 years that reside anywhere in the United States, and our exclusion criteria is the total colectomy. Our current screening numerator is 1,679, and these are individuals who have completed a FIT kit in the past year, completed a colonoscopy in the past 10 years, or completed a sigmoidoscopy in the last 5 years. On average, the clinic adds approximately 150 new patients every month, so our screening denominator is constantly changing with the addition of these new patients. This puts our current screening rate for March of 2019 at 47.4%. Our screening rates back in 2007 were 14% for the Oklahoma City Indian Clinic, and in 2017 we hit 64% despite a 27% increase in our patient population. Our screening rate for 2018 was 57.2%, with our goal remaining at 80%. The decrease was due to the GIPRA population logic change that affected all the area GIPRA results. And this is where we started back in 2016. I know it's difficult to read, but this was our initial process map before we started working on ways to improve our processes. And this is our current process map. So I'm going to talk about how we managed to get to where we are today. Initially, we developed a CRC QI team that fully focused on increasing our CRC screening rates and implementing evidence-based interventions clinic-wide in order to accomplish this. We began meeting monthly in order to begin our journey to accomplish our mission of being a national model for American Indian healthcare. Our CRC QI team consists of our Chief Quality Officer, our epidemiologist, our provider champion, our pharmacy director, the director of nursing, the Director of Public Health, our breast care nurse, and our public health case manager assistant. We also have representatives from the American Cancer Society and Southern Plains Tribal Health Board. By bringing this broad group together, it allows different perspectives and ideas to be discussed and evaluated and implemented, while still maintaining collaboration towards the goal of increasing our screening rate. Provider reinforcement is a key determinant in whether patients complete recommended screenings. When our CRC-QI team was looking to identify a provider champion to be a part of our team, we quickly were able to identify Dr. Jordan. Her patients already appeared to have higher screening rates, and she was invested in ensuring they received the recommended cancer screenings. Dr. Jordan is very beneficial at giving a medical provider's input in our meetings. She is also the one that we utilize for any colorectal cancer PDSAs that we trial during clinic visits. I'll go more into detail about our successful PDSAs that were recently completed by her and her nurse in a few future slides. So our evidence-based interventions, first and foremost, we have a nursing care protocol, and this allows our clinic nurses to distribute a fit kit to any patient that is screen eligible. Initially, we had noticed that we weren't tracking who was getting a fit kit, and therefore we weren't able to track who was actually returning it. And this led to the implementation of a checkout slip left out at the nurses' station. The nurse is able to write down the date along with the chart number and their initials each time a fit kit is distributed to a patient. The checkout slip allows us to put the information into an Excel spreadsheet and mark patients off as they return their fit kits. If a patient hasn't returned their fit kit at the 1 week mark after distribution, our QI administrative assistant makes a reminder call to the patient asking them to return their fit kit and making sure they don't have any questions about how to complete it. If at 2 weeks they still haven't returned their fit kit, they receive a reminder postcard in the mail. Originally, our fit kits had to be returned to our laboratory department at our main clinic building, and this required patients to walk through the lobby and back into the medical department in order to return their fit kit. We simplified this process by setting up 2 drop boxes in the main clinic lobby. One was by the pharmacy, and then the other one is by an entry door, so patients are able to drop them off at their convenience and not have to walk all the way through the clinic. We also added a drop box to our second building, which houses our gym and behavioral health, so that way they're able to also drop them off at that building and allows more convenience for returning their fit kits. And of course, they're also able to mail them back. If our patients return their fit kits and they are resulted positive for blood in their stool, we had originally noticed that there wasn't consistent notification for these results. So in a time span between October 2015 and June 2016, there was only about a 59% of patients with a documentation that they had been notified of their positive results. So at this time, we worked with our chief medical officer to create an EHR template so that I could personally ensure every positive fit kit was mailed an educational notification letter along with a handout about what to expect during a colonoscopy to help motivate patients to complete their procedures. Our clinic also publishes a quarterly magazine that's mailed out to all of our active patients. So every publication since the spring of 2016 has had a featured educational portion about the importance of completing colorectal cancer screening. And some additional evidence-based interventions that we use. We hold multiple health fairs every year, including a women's health fair, men's health fair, children's health fair, and an adolescent health fair. For the last 3 years, our screen-eligible women during Women's Health Fair were given a fit kit, and if they returned it, they were entered into a drawing to win a free hotel stay and breakfast at a local hotel downtown. We've seen a consistent increase in the return rates from this event, and so that's something we want to continue to do to motivate patients to complete their screening. And this year we also, at our Children's and Adolescents Health Fair, they had it as an emoji theme. So we had a booth handing out number 2 pencils with a little poop emoji on them, and they had a tag on the pencil asking the kids to give them to their parents and grandparents to encourage them to get screened. And then another way we've targeted educating children is at one of our fall kids camps. They had a quick and very basic cancer education lesson, and they participated in coloring postcards and competing on who would win the best colored postcard, which encouraged patients to get screened for colorectal cancer. And those are currently hanging up throughout our clinic for Colorectal Cancer Awareness Month. Approximately about a year ago, I began pulling an eye care list, which is our population management program that we use here at the clinic, and I would review the upcoming appointments that were due for screening. And then I would go in and modify the appointment title by adding to please give a fit kit to the patient or to document the colonoscopy. And this reminder is already in the chart for the patient, for the nurse or the provider to see, but it just gave an additional reminder to reinforce nursing staff and our providers that they are due and to make sure that it's mentioned during the clinic visit. Since making a push towards our CRC screening rates, we posted multiple lunch and learns for our nursing staff and our providers in order to continue to encourage and educate them on evidence-based interventions that are effective at increasing our screening rates. And National Wear Blue Day in March is National Colorectal Cancer Month. Every year there's a designated day within the month called National Wear Blue Day, and our clinic actively participates in this day, not only by wearing blue, we also try to do a fun photo booth for staff members, and our community development department posts these photos along with education on social media to show our patients and staff that we're having fun and that it's important to get screened. And while our patient population doesn't always have access to social media and smartphones, we do make an effort to post about CRC screening and risk factors on our Facebook, Instagram, and Twitter. Our community development department does a really good job at relaying all this information to the patients that do have this access to make sure that they have it available. Some more evidence-based interventions that we've been using. We host frequent clinic competitions. Some of these include which provider is getting the most fit kits returned or which nurse has distributed the most fit kits. For a few years, the nurse that had distributed the most fit kits would win a free entry into the Strollin Colon 5K race, which is a local race in the month of March, and also presented an award on race day for their efforts towards screening our patients. The providers get various prizes as well for participating and winning the clinic competitions. The competitions seem to get staff members talking and motivate them to screen patients, especially when we put a competition board up in an area where patients and other departments can see it. It becomes more competitive and motivating. We've also participated in FluFit. We initially implemented it in 2014, and patients, if you're not aware of it, are given their flu vaccine. When they get their flu vaccine, they're also offered their fit kit since they're in the screening state of mind. So we implemented a flu vaccine questionnaire, and on the back of it has our CRC screening questionnaire. This was effective at originally reaching out to some of our patients that were reluctant to be screened. We do still offer FluFit, but now we have a push for fit kit screening year-round and not just during flu season. So we kind of push it all year round now. Our partnership with the American Cancer Society has been extremely beneficial in assisting us with identifying barriers and implementing evidence-based interventions to combat the barriers. They originally were the ones that helped us develop a process map and guide us to further develop it. So without their expertise and guidance, we would not have had the success that we've been able to have so far. Lastly, our partnership with the National Colorectal Cancer Roundtable has been a motivating factor towards trying to reach our 80% goal of patients screened. In 2016, we signed the pledge as an organization that we would strive to accomplish 80% of patients screened by 2018. And in 2017, I submitted an application for the clinic to become a member of the roundtable. We later found out that we were accepted, and we were the first small non-hospital organization to be accepted as a member of the NCCRT. This membership has opened a lot of doors towards multiple awards and recognitions that we have received, also including winning their National Achievement Award in 2018. And for those that aren't aware of what PDSA stands for, it's a Plan, Do, Study, Act. And so we do multiple PDSAs around our clinic, and we've done a lot of them to improve our CRC program. Our most recent one included providing prepaid return postage for all fit kits that were distributed during clinic visits to our patients if they were seeing Dr. Jordan, our provider champion. So we trialed this for a 3-month period and tallied up the results, and this showed a 4.6% increase in our fit kit return rates for Dr. Jordan. So we're implementing it to a few other providers right now to see what kind of return rates we can increase with their patients. This also showed multiple patients that had documentation in their chart that they had been distributed fit kits in previous years but hadn't returned them in the past. But by providing them postage on the fit kit so that they could return it without having the transportation barrier or the financial barrier of buying stamps, they were able to return it and get screened. And then interdepartmental collaboration has been a huge factor in the success of our screening program. And so I'm going to go more into that on our next few slides. You can utilize interdepartmental teamwork through your quality improvement team. Our quality improvement team, of course, includes our Director of Public Health and along with our breast care nurse and case manager assistant. So we utilize these individuals in a team screening approach in the following ways. The public health nurses are able to distribute fit kits when patients walk in for immunizations and TB skin tests. They can also access patients in our optometry and physical therapy departments in order to distribute fit kits to individuals with scheduled appointments in these areas. Our CHR also hands out fit kits when she goes to transport patients to and from the clinic if she is aware that they are due to either receive one or that they have one that needs to be returned. Our mammogram van is ran by one of our breast care managers, but the case manager's assistant is a huge asset in assisting with mammogram van days. She has her medical assistant certification and keeps a list of patients who have scheduled mammograms that are also due for CRC screening so that she can assess the completion of the colonoscopy and or give out a fit kit. Once the mammogram van day is completed, she gets me a list of the chart numbers so that they can be added to our phone call and postcard reminder list. The mammogram van fit kit return rate is greater than 50% and seems to show a huge success similar to flu fit. Since these patients are in the screening state of mind when they come in for their mammogram, it's easier to talk to them about screening for other cancers such as colorectal cancer. The Director of Public Health reorganized our public health department in order to add a much needed oncology case manager as well, and she's currently managing approximately 300 patients. The addition of this department allows our oncology patients to have access to a designated individual for referral and progress questions, and it helps to eliminate confusion on if referrals have been completed. The oncology case manager advocates for our patients in multiple ways, and one notable recent one was transferring our patients on active chemo treatments to our public health department for lab draws. This prevented them from having to sit in the clinic lobby with individuals that were here for sick visits and flu visits. The oncology case manager also manages a cancer registry within our clinic to track the cancer diagnosis and staging for our patients so that the clinic can observe any patterns. And then our work with our pharmacy department was integral in our ability to reach our 64% of patients screened in 2017. In previous years, the nursing department spearheaded our walk-in flu vaccines and therefore administered the fit kits to individuals that were due. In 2017, pharmacy began to take on a bigger role in administering walk-in flu vaccines. They agreed to also complete the CRC screening questionnaire alongside the vaccination questionnaire. And the pharmacists and pharmacy students distributed fit kits to individuals due for screening that walked in for flu shots. This allowed us to continue our flu fit campaign despite pharmacy taking over the walk-in flu vaccine request. A lot of our patients will continue to utilize the pharmacy department despite not having a primary care visit in the past year. And our pharmacy uses a GSL system to separate from the medical department. What had the biggest impact on our screening rates that year was when the director of pharmacy agreed to manually add a pop-up notification to individuals' GSL charts who hadn't had a medical visit in the past year but had been picking up medications monthly. The pharmacy techs would provide the patient a fit kit and education along with their medications. After the fit kit was distributed, they would provide me with the tracking sheet so that we could make sure they got their reminder calls and postcards. This single addition to our screening method increased our screening rate by 3% in a 2-month time span. This would not have been possible without interdepartmental teamwork and really proves what can be accomplished when a team approach to healthcare and quality improvement is taken. And if anyone has any questions, I'll be happy to answer them.
All right, well, thank you, Jessica, for sharing this valuable information. And we do have a few questions for you. Would you be able to talk a little bit more about how your clinic was able to engage your partners for your CRC efforts?
I'm guessing this is in regards to the American Cancer Society and Southern Plains Tribal Health Board, is that correct?
Yeah, the different partnerships that you mentioned who helped you in your screening efforts.
We have worked with American Cancer Society in the past, and so it's really just reaching out to them and seeing who your representative is in your area, and making sure that they know who you are and asking them to come out and work with you on any of your cancer care questions and trying to develop a plan to increase your screening rate. That has been the main thing, is just reaching out to those organizations and trying to develop a partnership.
Okay, have you found that they're very open to working with you?
Yes, I don't think we've reached out to anyone that has shut us down as far as working together to accomplish increased screening goals.
Great. I have another question. Do the health fairs that you mentioned involve clinic departments only, or do you also engage community partners?
We also have community partners that come and set up booths in the lobby for education. So each health fair is geared a little bit different at who is invited based on, if it's pediatrics or adults, women's or men's. But we try to make sure that we always do cancer screening and cancer education at all of those health fairs.
Thank you. What age does your clinic start screening with American Cancer Society and American Indian Cancer Foundation advocating for American Indians to start screening at age 45? Is that something your clinic engages in as well, or is it age 50?
We're still following the USPSTF recommendations, which is age 50, as far as for fit kits distributed. However, of course, if a patient has a family history, or is a high-risk patient, we will definitely get them screened earlier with a colonoscopy referral placed.
Great. A couple more questions. How do you make sure all clinic staff share a uniform message around colorectal cancer screening? I know one thing you mentioned were like lunch and learns.
Yes, we do the lunch and learns. We have morning huddles once or twice a week, every week. So any kind of updates with screenings or changes can be mentioned there. All the medical staff attend it. It's like a 5 to 10 minute meeting before clinic starts. I think that we've been doing it so long now at this point that everyone kind of expects screening to take place, and they know who to go to if they have questions. So they'll call me if they have any kind of questions about what needs to be done as far as screening goes.
Okay. And then what EHR does your clinic have? Has it been helpful in running reports to help you in your efforts, such as identifying patients due, patients who have been given a fit kit, that sort of thing?
Our EHR, I believe, is just EHR. I know it's an older system. It does have a reminders tab on it to remind us to distribute the fit kits, but it does not help us at identifying who's returned them. I've been set up on the lab notifications, so any fit kit that's returned, I'm automatically notified of. So this helps me manage it, but as far as running reports, we're looking at getting an outside system to assist with that.
Okay, great. And then the last question, how can people reach out to you if they want to get a hold of you?
You can email me. My email is jessica.d@OKCIC, which stands for Oklahoma City Indian Clinic.com.
Okay, thank you. Well, thank you
You're
all
welcome.
for attending today's webinar in partnership with the American Indian Cancer Foundation and the Oklahoma City Indian Clinic. Again, be on the lookout for a follow-up email with a link to today's recording. And in addition, an email from Robert Spencer has been sent to your inbox, and this includes a brief survey that we would greatly appreciate you to fill out to give us feedback about today's webinar and format. And as always, please contact us at the American Indian Cancer Foundation by emailing health@aicaf.org